Is my screen visible?
Yes, thank you.
Okay.
Okay, should we start?
Yes, please.
Did I send you the PDF version?
Hello, sorry.
Did I send you the PDF version or was it a PowerPoint presentation?
It was a PDF version.
Oh, okay. All right,
Yeah, so
good.
I'll just go through.
So, good evening, everyone. It was short notice. Temur texted me in the morning and busy at that time, so we have decided to do it at this time. So that's the outline. We will not talk much about management because that will come next year when you guys come to the pediatric rotation. So we'll talk about the other features. All right, next slide, please. Okay, sorry, I think it's projecting, at least on my laptop, it's projecting a bit whatever, but it's because of the PDF version. So yeah, that's better. No, the other one was better. Okay, yeah, that's better. That's better. Thank you. So we all know that diarrhea is, as defined by World Health Organization, is 3 or more loose stools per day. Can anyone tell me what loose means in this context? Anyone willing to give it a go? No? Okay. So loose is taking the shape of the container. That's what basically it means. Okay. So there are different definitions of diarrhea, but this is what is recommended one currently. Then acute diarrhea is diarrhea less than 14 days. If it's more than 14 days, it becomes persistent, or some call it chronic diarrhea. And dysentery is if there's blood in stool. That's dysentery. It's simple like as that. Okay, next slide, please. So what do we know about epidemiology? It's the second leading cause of death in children under the age of 5 years. So who can tell me what's the most common cause of death in children under the age of 5 years if diarrheal disease is the second? Come on, that's an easy one, guys. Malaria? No, good try. Pneumonia, yes. So pneumonia is the leading cause of children of death in children under the age of 5 years. So diarrhea accounts for 9%, so almost 10% of all deaths amongst children under the age of 5 throughout the world. That means, if you think about it, that means 1 in 10 children almost die because of diarrheal illnesses. And if you break it down further, it comes to 1,400 children dying each day. What about more than half a million children dying every year because of diarrheal illnesses? That's a lot of children who die because of seemingly preventable illness. Okay. Kenya, that Kenyan data also shows that we have a lot of morbidity and mortality due to diarrheal illnesses. And so it's what 7% of total deaths in children under the age of 5, according to the Kenya Demographic Health Survey of 2014. So that's still a lot of children also in Kenya who are dying because of diarrheal illness. Now, the good news is that the number of deaths has actually gone down by almost 50%. It used to be 1.2 million, and now it's down to about 500,000. So that's good news, but the numbers are still very, very high. Next slide, please. Okay, so um, as mentioned in the previous slide, we have had dramatic improvement, 50% reduction in deaths, and it's mainly been attributed to the rotavirus vaccination, because we know that rotavirus is one of the most common causes of diarrheal illnesses in children. We think there has been some better management both at home and in hospital, as well as improved nutritional management of children who come in with diarrhea. But 500,000 children is still a lot of children who are dying, and mortality is still high, we think, because there's still a little bit of delay in seeking care, both in the home setting and within the community, and delay in instituting care to prevent and treat dehydration. And sometimes it's suboptimal care. So a child presents with diarrheal illness, and if we don't make correct diagnosis that this child is dehydrated, leading to, especially if it's severe dehydration or shock, then the chance of dying are actually high, and the odds are more than eightfold for children who come in with severe dehydration or some dehydration. Next, please. All right. So, in terms of etiology, the causes are multiple and varied, and they usually vary from region to region. However, what is known is that viral infections, and especially rotavirus, is the most common cause of diarrheal illness in children under the age of 2 years worldwide. Okay, so it's something to remember, and thank God we have a vaccination now available. Okay, the other causes are as on the table. So E. coli, Vibrio cholera, Cryptosporidium, and norovirus. Norovirus is the other virus that is now coming up because of the vaccination against Rota. So we are now seeing more and more norovirus diarrheal illnesses. Then we have the invasive types of diarrhea, and that's usually caused by bacteria, so Shigella, Salmonella, Campylobacter, and all those play a role in the invasive types of diarrheal illnesses. Next, please. So this was a study done in multiple countries, and Kenya was one of them, looking at causes of diarrhea, especially in developing countries. And as I know, it's a bit of a busy slide, you might have to strain, but if you look carefully, rotavirus, thank you, Temur. So rotavirus is clearly the most common cause of diarrheal illness in children under the age of 1 year, okay? And Cryptosporidium is the next most common. And then in the next age group from 12 months to 23 months, rotavirus still remains the most common cause, and Cryptosporidium is still there, but Shigella species seems to be also quite common in that particular age group. Then if you look at the older children, so children between 2 years and 5 years of age, then rotavirus is not that much of a significant cause. Shigella now is the most common cause. But if you look at the numbers, the numbers are also much lower after the age of 2 years. So the first 2 years are the most critical as far as diarrheal illnesses in children are concerned, and therefore giving the vaccination early on in life is, together with the routine vaccination, makes a lot of sense. And we have indeed seen a dramatic reduction in diarrheal illnesses, especially from rotavirus. Next, please. Okay, so this is basically the same information now in chart form. So We talked about rotavirus as the most common cause in under the ages of 12 months and 12 to 23 months. And then for the older children, bacterial causes seem to be much more important than viral infections. Okay, next. Now, as doctors and clinicians, uh, we know that common things happen more commonly. So we'd always talk about infections, rotavirus, norovirus, Vibrio cholera, Salmonella, Shigella, etc., etc. And indeed, this is we have to think of infection as the most common cause when we see a child with diarrhea and vomiting. But we need to remember that there are non-infectious causes which can cause diarrhea in children. So don't be stuck that everything is rotavirus and you just have to give ORS and zinc and that's it. You as a physician, when you go out there and you see children with diarrhea, and especially when it is persistent or chronic diarrhea, then you must think about other causes of diarrhea. So we've listed a few according to this table from up to date, but just remember that malabsorption, inflammatory bowel disease, pancreatic diseases, motility disorders, thyroid issues, etc., can also cause diarrhea. Next, please. So just a brief reminder about gut physiology and as far as uh, liquid absorption and secretion is concerned. So you need remember that um, even in the normal fasted state, there is still production going on of liquids. Okay, so we have saliva being produced. Then we have the stomach also producing its own liquids. Then there's bile. The pancreas also produces quite a bit, and as does the bowel. In total, we are having we have almost 8 to 9 liters of liquid, quote unquote, being produced that most of that is actually absorbed, and most of it is absorbed within the small intestine, especially within the jejunum and then the ileum. And then whatever water is there that has not been absorbed is absorbed in the colon. So whatever is being produced by the gut is actually, and of course, whatever we take in terms of diet is mostly reabsorbed. And so, according to this definition, so if more than 200 mLs of liquid is excreted, then that is actually defined as diarrhea. And that's a definition used by research scientists, and sometimes people are doing studies and all that, so they would need to quantify rather than use the WHO definition of more than 3 bowel movements in a day. Okay, so this is something to remember, and the point here is that sometimes we have children and mothers say that child is not eating and yet he's still passing stool, and yet he's not eating anything for the last 2 days. And then the reason for that is because the gut keeps on producing uh, liquids, quote unquote. Okay, so you need to remember that. Next slide, please. Okay, so most infections are transmitted from person to person or from the fecal-oral route, and is usually because of ingested contaminated food or water, ingestion of contaminated food or water. Okay, incubation period varies from few hours to several days, and in some cases it can last up to 14 days. For Entamoeba histolytica, it may be even longer than that. Okay, and so what you have to remember is that diarrhea is secondary to excessive secretion compared to absorption across the intestine. Next, please. So what happens with rotavirus? Rotavirus tends to affect small bowel mainly, Okay, so it invades the small bowel epithelium and causes a bit of destruction and shortening of the villi, which when the villi are shortened, you remember that most of the absorption takes place at the villus level. So when the villi are shortened or destroyed, then there is loss of absorptive capacity. And the enzymes which help in digest food, especially lactose, so that's lactase enzyme, is usually right at the tip of the villi. So if the villi have been destroyed and have been shortened because of the destruction, then the enzymes have also been destroyed. And one of the reasons for the diarrhea, therefore, is that food or milk or whatever it is that the child is taking is not getting absorbed and is simply coming out in the stool. And whenever the villi regenerate, then you will see recovery happening gradually. Next, please. So in invasive diarrhea, um, then you have um, bacteria which actually invade uh, the intestinal epithelium and destroy the mucosal cells. So this, remember, the rotavirus is, it's not invasive as such. It's patchy invasion, and there's a little bit of, it's mainly at the superficial surfaces at the villi level. Whereas now in some of these bacterial infections, it's the invasion is into the cells itself, and so the mucosal cells are actually destroyed, and many of these bacterial infections tend to prefer the later part of the small intestine, so there's the ileum and in the colon. Okay, then we have the secretory type of diarrhea, and so we have toxins, especially from Vibrio cholera and some forms of E. coli, which affect uh, the secretion and absorption of electrolytes across the intestinal epithelial borders, and which then leads to excessive secretion of water and electrolytes. Next, please. Okay. Some of the protozoa like Giardia tend to adhere to the small bowel epithelium, so they don't actually destroy uh, the the cells, the epithelial cells, but they just kind of attach onto the epithelium and basically reduce the surface absorptive capacity, because they're just sticking on like gum onto the gut. Okay, we talked about invasion by bacteria, but some of the protozoan like Entaema histolytica can also invade the epithelial cells, especially in the large intestine, causing microabscesses, ulcers, leading to excessive secretions or diarrhea, and of course, blood-stained diarrhea as well. Next. So what's the clinical presentation? I mean, we all know the child is going to come with loose stool. And so when we're taking history, we need to try and quantify that particular aspect of stool. So we need to talk about initially, of course, the number of bowel movements in a 24-hour period, consistency, color may give us a clue. Of course, we need to ask about presence of blood, mucus, okay? And sometimes it's large volume diarrhea and sometimes it's small volume diarrhea. And then, so it gives us clues as to where the pathology might be, okay? Presence of blood, mucus is a sign of inflammation usually going on within the gastrointestinal tract. And when you see undigested food, that tells you that, again, the absorption has been clearly been affected. We need to talk about other GI symptoms, so nausea, vomiting, abdominal pain, etc. That needs to be inquired into. Ask for systemic symptoms, so fever, weight loss, etc., etc. In most instances, we have viral infections which are easily transmitted. So we talked about person to person and fecal oral routes. So if there's been history of contact with someone with similar symptoms, usually it's school or within the home. So that's important history. And then anything, if there's a change in diet. So for example, this is a 9-month-old baby who was previously breastfed and was weaned on fruits and vegetables. And then maybe at 9 months, the mother decided to give this child, this infant, cow milk, packet milk, for example, and the baby develops diarrhea or loose stools. So that change of milk uh, may be the trigger for the diarrhea. So it's important to take that history as well. Next, please. Okay, so if the small bowel is affected versus large bowel, then there's some clues. Okay, and we talked about viral infections or rotavirus mainly affecting small intestine, whereas many of these bacterial infections tend to affect the large bowel. And so, if it's very watery stool, that's a sign of small bowel. So that's large volume watery stool. So that's you're talking about jejunum and probably terminal ileum getting affected. If it's mucoid and bloody, that's inflammatory signs of inflammation, and it's usually tends to affect the large bowel. So you'll have small volume diarrhea when your large bowel is affected. Okay. Then the other characteristics which one may be able to look for. So not always there, but reducing sugars if maybe positive, especially in the small bowel is affected. And in large bowel, when you have mucoid and bloody stools, you're more likely to get higher white cell count within the stool specimen. And when you see pus cells and a lot of white cells, then you know that this is most likely a large bowel getting affected. So we say viruses tend to affect the small intestine, whereas bacteria tend to affect the large intestine. Okay? But of course, it could be viruses affecting large intestine and bacteria affecting small intestine as well. Now, Giardia tends to prefer small intestine, so they kind of coat or attach themselves on the small intestinal epithelium as well. Next, please. Okay, so some of the clues as to what cause might be. So children in daycare or in nursery schools, when they get acute episodes of diarrheal illnesses, you know that the most likely cause is going to be viral. So rota, norovirus, astroviruses, etc. And sometimes some of the bacteria can also cause that. If someone has traveled, then you start thinking about enterotoxigenic E. coli. If somebody has taken pizza and develops diarrhea and vomiting immediately afterwards. So possible etiological factors are Campylobacter or Salmonella that tends to prefer dairy, whatever. Again, Salmonella in eggs. So if you had an egg sandwich and you start vomiting and having diarrhea, then you think that there might be some Salmonella somewhere. For meats, it's Clostridia and Campylobacter. And for beef, sometimes it's E. coli. So, I mean, these are clues. It doesn't have to be that, but it gives you an idea as to what the possible etiology is. Next, please. So, when you have the child, you've taken the history, now you need to examine the child. Vital signs become very important. And we talked about hydration status and this, whether the child is malnourished or not. But in vital signs, one of the key things is actually the heart rate, okay, or the pulse rate. Because if there is a tachycardia, that's many times a sign of volume loss. I mean, if the child doesn't have a fever, and tachycardia is one of the first signs of volume loss. So we need to be cognizant of that, that this child is probably dehydrated at that point in time. So I know that heart rate may not appear in the next few slides, but it's for us to remember that tachycardia is an important marker of volume loss. Next, please. Okay, so we need to assess the degree of dehydration. find out if there is a fever, ideally get a weight and height as well as upper arm circumference to know the nutritional status. If the child is unconscious or has reduced level of consciousness, the child is having seizures, and that could be a complication of diarrheal illness because of electrolyte imbalance or perhaps hypoglycemia. Um, if on examination the abdominal pain is out of proportion to what you see when you examine, then you start thinking of an abdominal emergency, an acute abdomen. Okay, so you have to have these differentials in your mind as you examine a child who comes in with diarrheal illness. And it's always a good idea to look at the poop yourself. Okay, it gives you several clues, and many times parents miss out on these things. So it's if possible, try to look at this yucky stuff as well. It's part of your training. Next, please. So um, dehydration assessment. Previously, we used to quantify this as mild, moderate, severe dehydration. The current guidelines suggest we do no dehydration, some dehydration, severe dehydration, as well as shock. And those are the parameters that have been listed there. So you look at the eyes, whether they are sunken or not sunken, whether the child is thirsty or not. So if the child is thirsty and is drinking well, so you already know that you are not in the realm of severe dehydration. But if the child is not drinking and drinks poorly, now you know you're in trouble. That particular child is in trouble and needs urgent attention. So there's skin pinch, and then there's an estimated fluid deficit. Um, Next, please. Okay. Now, you guys will be taught this when you come to for the pediatric senior rotation, and we'll go through the ETAT plus course, and we'll go through this as well in the wards. But so it's important to remember the stages of dehydration, because some dehydration, severe dehydration, especially shock, if not treated, then we can lose that particular child. Next. Next, please. So, do we need to investigate every child who comes in with diarrhea and vomiting? The answer is no. Okay, in acute gastroenteritis, we know that in most instances, it's going to be viral infection that has caused the gastroenteritis. Rotavirus, as I said, vaccination has indeed resulted in a reduction, a dramatic reduction, but it's not that we don't get rotavirus. We still get rotavirus as the most common cause of diarrheal illnesses, despite the vaccination, but we're seeing milder forms of rotavirus gastroenteritis. Okay. Sometimes we may ask for the stool test. So presence of mucus, blood, and leukocytes is important. It tells you that there is some inflammation going on. And then we might, if necessary, we can ask for specific tests to look for rotavirus. I mean, it might not change our management at all if rotavirus is positive, but at least it gives us an idea that this is most likely viral. This is rotavirus or adenovirus or norovirus, whatever it is the test comes positive for, and you know that you need to just emphasize on conservative management and rehydration basically. Bacterial infections are not that common, as we talked earlier. So we may need to culture to identify the actual pathogen, okay? But cultures are not routinely recommended. However, if you have a very sick looking child, if you have blood in stools, if you have dysentery, then you need to get a stool culture at that point in time, or if the diarrhea has lasted for longer, and if the child is having very high fevers and, as I said, is very sick looking. Next. Okay, so the most important thing is to replace what has been lost. Okay, so you need to replenish deficits in water and electrolytes. That's the most important thing. And it's continued till all signs of dehydration are resolved. So usually in the first few hours, now you've replaced adequately, and you know the child is well hydrated. Okay. In the maintenance phase is to now counter the ongoing losses, and that is until all the symptoms have resolved. So remember, you need to replace what has been lost uh, in the first phase, and then the maintenance phase. By replacing doesn't mean that the child will stop having diarrhea or vomiting. No. So the child comes in, has vomited 10 times and has had diarrhea 5 times. So the most likely thing, the child has lost quite a bit of fluid. So first and foremost, let's replace that. Once we have done that over 4 to 6 hours, then the next phase now, and the child will still continue having loose stool. So you keep on replacing that particular volume. You estimate and you replace. Okay. So what do we give as fluid of choice? We are always told and taught that use the gut when you can. So oral rehydration solution is one of the best things to use to replace the losses. Okay. But in severe cases, especially with severe dehydration and shock, of course, we need to use IV fluids. Next, please. All right, so this is the formulation of the current oral rehydration solution. The old oral rehydration solution ceased to exist, I think, about 5 years ago. No one manufactures it anymore. It used to be there during our time, so don't worry, no one will ask you that question. What you have to remember is that the old ORS was much more hypertonic, and the new one is more isotonic. Okay, so if you look at it, the sodium and level is lower than the previous one, and so the osmolarity is actually quite low compared to the old ORS. Next. Okay. You can skip this slide. It's fine that ORS is clearly efficacious. Go on to the next slide. Okay, so now we talk about management of dehydration. So you guys have the slides, and I think you can read this at your own free time because we're going to discuss this in detail next year. Next. Okay, so talk about how to treat shock, how to treat severe dehydration, some dehydration, and then no dehydration. All right, next slide, please. Next. Thank you. All right, so nutrition management becomes important. So in a child who is having diarrhea and the child is breastfeeding, then we need to encourage breastfeeding as much as possible. In an older child also, we need to keep on offering foods because there are certain cultures whereby when a child is having diarrhea, um, the cultural practice is to stop feeding the child. So to what's known as rest the gut. Um, and the thinking is, I mean, it's straightforward. I mean, if you give anything to the child to eat or drink, it's simply going to come out in poo. So why don't we just rest the gut, wait for the gut to recover, and then we'll start feeding the child. Whether it's 1, 2, 3 days later, we'll start feeding the child after the child has recovered. But we know that that is actually flawed mentality and flawed policy. The child needs to be fed, especially children. I don't know about adults if they want to rest the gut, but children, we need to feed them. It's true that the enzymes have been lost. There is shortening of the villi, so the absorption capacity has been affected clearly. Nevertheless, we need to keep on feeding. Some of it is going to be lost in diarrhea, but some is going to be absorbed, and that's extremely important for children. Okay. Now, there was a study on whether we need to, as I said, wait until later on to reintroduce feeds or just introduce feeds early on. And there's evidence to suggest that early feeding is actually better than delayed feeding for children with acute diarrheal illnesses. Next. Next slide, please. Okay. Zinc has been recommended over the last several years now, almost 10 years. So studies clearly showed that using zinc reduced the stool frequency, it reduced the diarrhea duration, and the interesting fact was that it also reduced subsequent episodes of diarrhea. So the dose is usually 10 milligrams of zinc per day in infants under the age of 6 months, and 20 milligrams per day for those over the age of 6 months. Next, please. Do we need to give antibiotics? The answer is no. In most instances, we don't need to give antibiotics. In most instances, we know that viral infection are the most common cause. So we don't need to prescribe your metronidazole and your ciprofloxacin and whatever it is that people prescribe in most instances. Okay, if we have somebody decided to do a stool culture and the stool culture clearly grows pathogenic bacteria, at that point in time, certainly we can give. If we have blood in the stool, so if you have dysentery, then yes, you are allowed to start an antibiotic. Okay, so for Shigella, for cholera, of course, if the child is septic, then we can start antibiotics. Now, Giardia and E. solitica sometimes need to be treated as well. And in some select cases, a non-typhoidal salmonella in children at the age of 3 months may require antibiotics. Immunocompromised patients and children, so from whatever reason, whether it's HIV or because of malignancy or whatever, they are more prone to infections and even viral infections. And at that point in time, you may consider antibiotic early for such children. Okay, next slide. Can we give antiemetics? So the WHO guideline currently does not talk about antiemetics. So medications like domperidone, that's motilium, and others are not recommended by the World Health Organization. Now, there are newer antiemetics in the market, no guidelines from WHO, but there are studies which clearly show that, for example, ondansetron, a single dose of ondansetron clearly reduces vomiting, stops the vomiting, and because of that effect of the ondansetron, a single dose, if the child stops vomiting, the child is more likely to take the oral rehydration solution, retain it, and recover faster than a child who keeps on vomiting. Okay, the previous agents and anti-vomiting agents were associated with many more side effects, and therefore they are not on the recommended list. But ondansetron is, although it's not on the guideline, but a single not parenteral but oral dose of ondansetron may actually help quite a bit. Okay, next slide. So anti-diarrheals, do we use anti-diarrheals in children? And the answer is generally no, unless we have persistent or chronic diarrhea, then we might use it. I know adults love to use this. They self-medicate every time they have a bit of loose stool, they'll go and take 2 capsules of Imodium, but not recommended in children. Next. How about probiotics? So there are many probiotics in the market. Many of them tout many wonderful and magical effects. The truth of the matter is that there is some evidence that probiotics may help in certain conditions, but in other conditions, there's no evidence that probiotics help. Okay, so there have studies show that there is a slight reduction in the duration and stool frequency when using probiotics. Okay? What are the disadvantages? Most of these probiotics, they're not labeled as medicinal products, so they're not well regulated. There's a lot of variation amongst the brands and how much active microbiota is in each probiotic. And so no one really knows what's the optimal type, what's the optimal dose, and whether to give it 1 a day, 2 a day. So those are all questions that are out there. Okay, next slide. So some of the guidelines that come from the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition on acute gastroenteritis. But these, remember, are for children based in Europe. So this is not for our setting. Next. And they talk about other interventions that may be considered. So first and foremost, we must remember we need to rehydrate. Okay, we need to correct shock. We need to correct severe dehydration, some dehydration. So ORS, we need to give zinc. Okay, clearly there's evidence that zinc is helpful. And then probiotics may be used on case-by-case basis. And other interventions would include lactose-free feed. So remember, we talked about the lactase enzyme is the one that's destroyed. It's at the tip of the villi. So if you give lactose-free foods, then they're better absorbed. There are the medications, diosmectite and racecadotril, that also have been listed as possible interventions, but those are not under the World Health Organization guidelines. Next. In our setup, our best and whatever action is to prevent diarrhea from happening in the first place. Easier said than done, but if we all put our heads together, if we have the political goodwill, then we can make this happen. So safe water, adequate sanitation, okay, good hygiene practices. One of the positive effects of the COVID pandemic has been that a lot of people have started washing hands when they were never used to, so that's a good thing. And the truth of the matter is that those of us who see children, even in private practice, the diarrheal illnesses were down last year. Okay, well, children were not interacting with other children, schools were closed. But at the same time, everybody was like sanitizing their hands and washing their hands so much that it has actually helped. Okay, so appropriate and adequate nutrition plays an important role in preventing diarrheal illnesses, as does breastfeeding, especially exclusive breastfeeding for the first 6 months of life. Okay, there's some suggestion that micronutrient supplementation, so vitamin A, zinc, early on may also help prevent diarrheal illnesses. And of course, the key intervention has been immunization against rotavirus. Next. Okay, so this is the study that done on rotavirus when it was being investigated, and you can see that it showed an almost 50% overall protective efficacy against rotavirus gastroenteritis. This is in children within developing countries. The initial efficacy rates in developed countries were over 80%. But in what is known as real world data in our part of the world, it was not 80 to 90%, but it was about half of that, so about 50%. But what is known is that 50% is better than nothing. So 50% would save hundreds of thousands of lives. Okay, so the overall protective efficacy may not be that great compared to Western countries, but it is still an important one. Now, the interesting uh, factor that came across also was that there was a protective efficacy against all-cause severe gastroenteritis. What does that mean? It's not just against rotavirus. So infections from diarrheal illnesses from other infections, especially other viral infections, so adeno and noro and all that. I mean, what rotavirus vaccination showed is that not only is there efficacy against rotavirus infections, but also against non-rotavirus infections. So that is something extremely positive and very helpful. Next. So in summary, I think the summary slide, Timur, please. Okay. It's not projecting on my screen, but it's okay. The most important thing is that rotavirus is the most important cause of diarrheal illness in children under the age of 5, especially under the age of 2. We showed you the evidence for that. Diarrheal illnesses is the second most common cause of death in children under the age of 5, killing almost 500,000 children a year. So we need to do something about it. So early recognition and appropriate interventions are very important. ORS remains the mainstay, but zinc has also proved to be helpful in reducing the frequency and the duration of diarrheal illnesses. There is some role that probiotics may help, but it's still not part of the World Health Organization guidelines. And again, there's some role that certain new antiemetics may help, a single dose, but again, not part of the World Health Organization guidelines for now. Okay, I think that's the end of the presentation. Now, if there are any urgent questions, I can take them. Otherwise, if you can, you have my email address, guys. You have my telephone contacts. If there are any questions, you can just send the questions to me directly. I have a doctor who's been calling me for the last half an hour. His child is very sick. So if you don't mind, let me just attend to the doctor's child, okay? Thank you.
Thank you. Thank you, Dr. Lavin, for your time this evening.
Thank you. Bye.
Thanks.
Recording stopped.